Hello, welcome to JAMA Live. I'm Seth Kruger, Digital Media Editor at JAMA Network Open. Of course, if you're following on live, please send us your questions or comments on Twitter at JAMA Network Open or into Facebook or YouTube Live in the comment box. Today, we are talking about race ethnicity among children with COVID-19 associated multisystem inflammatory syndrome. And we have first author, Dr. Ellen Lee, with us. Welcome, Dr. Lee.
Thanks so much.
So first, can you give us a little background, who you are, what you do, and why you did the study?
Yeah, sure. I'm a pediatrician and I work as a medical epidemiologist at the New York City Department of Health and Mental Hygiene. And in that capacity, I work on surveillance for different infectious diseases. During our agency's response to the COVID-19 pandemic, I've been working with a large team, working to conduct surveillance for COVID-19 and to really try to understand the epidemiology of the virus in New York City.
Okay, great. And this is an interesting study where you took a lot of the data, the citywide data on children who were hospitalized with COVID and looked at the kind of disparities across racial and ethnic groups with, how do you pronounce it, MISC or MISC?
Right. People refer to it as MISC or MISC, and then in Europe it has a different acronym. So yeah,
Right.
but generally
Yeah,
it's MISC in the States.
right. And this is we've been talking about it now for a few months, is basically the Kawasaki-like syndrome that some critically ill children with COVID can develop, right?
Right. In fact, though, earlier on when there were those initial reports that were coming out of Europe and the UK, it was described as a Kawasaki-like or a toxic shock syndrome-like illness. But in fact, I think that the spectrum is much wider than that. And so there are some similarities, but important differences between MIS-C and Kawasaki disease. So it now more goes with MIS-C with some overlap with Kawasaki.
Good, interesting. And it looks like altogether you have about 223 patients who met criteria who are under 21 and hospitalized in New York City with what sounds like likely MISC. Median age is 7, but the IQR was 3 to 12, so a pretty broad age range. And what were the important findings you had here?
Yeah, so maybe just to give this study, when we initially started to hear about these reports or these alerts from Western Europe about this syndrome, we started to contact the pediatric intensive care units within New York City to ask if they had patients with a compatible illness. They had, so we started to ask for all the facilities in New York City to report these potential cases to us. And so in that process, as we were learning about these cases and reviewing the data from these cases, we had a team of medical epidemiologists who were abstracting clinical and laboratory data. We noted that there was a large proportion of cases among children of color, specifically Black and Latino children in New York City. And as people were starting to report on their experience with MIS-C, both domestically and internationally, some, although not all investigators, also described a large proportion of cases among children of color. And these case series that came out were really important. They described their patients with great detail. But as case series, they were limited because they could only describe the patients that presented for care at their institutions. So what we did in our work is that we looked at all the cases that had been reported to us at the City Health Department. So we could look at all MIS-C cases throughout the city and then use our sort of population data to try to look at disparities in MIS-C among different communities within the city. So with that context, we certainly had a large burden of MIS-C in New York City, as one might expect based on the idea that it is a post-infectious phenomenon. And we had such a huge burden of COVID-19 earlier on that it wasn't surprising that we had quite a large burden of MIS-C. And we saw our peak of MIS-C about 4 to 6 weeks after our peak of COVID-19. And that's been what others have described both, again, domestically and internationally. You see that sort of peak of MIS-C anywhere from a month, give or take a couple of weeks after you see that peak in the epidemiology of the disease. So given that we had over 200 cases, we were able to look at the distribution of race and ethnicity. And so what we did was we looked at race and ethnicity among our cases of MIS-C. And then we also, to give it context, we looked at race and ethnicity among our confirmed cases of COVID who were hospitalized. And we did this all for children under the age of 20. And we were able to use our population data to look at again, race and ethnicity among our whole city. And so from that, we were able to sort of document disparities that we were seeing even among all the different institutions that were reporting cases to us.
Okay. That's really great. I think, I'll admit most of my knowledge on the COVID epidemiology is among adults. We've certainly seen a lot of disparities in COVID epidemiology in adults across race and ethnic lines. But most of it seems to be on who gets sick, probably a combination of things like essential workers, inability to telecommute to work, and then comorbidities, other social determinants of health. But a lot of the disparities kind of seem to attenuate once you hit the hospital. Once you're sick enough to actually get admitted, everyone's treated about the same and does about the same. What did you find here?
So what we found is that, so again, we sort of looked at it in different stages. So one was looking at the proportion of, or the distribution of race and ethnicity in our city. And we saw that given that about 20% of our city, of the population under 20 is Black children, we actually had a much higher proportion of children with MIS-C who were Black compared to our New York City population. And then also a higher proportion who were among the hospitalizations. And so what, in addition to that, we also found when we compared incidence rates of MIS-C among Black children and among Hispanic children, and if you use the reference group of white children as the reference group, then we found that there was actually an increased burden among Black and Latino children as well. So sort of looking at our data in a couple of different ways, we were able to document a disproportionate burden of MIS-C among specifically Black and Latino children. It did seem that white children and Asian American and Pacific Islander children didn't really seem to have much of a difference in terms of MIS-C or COVID-19 hospitalizations.
Okay, and then looking at things like underlying medical conditions, it looked like less than 1 in 4, maybe 1 in 5 kids had some sort of comorbidity, which is lower than what we see in adults, fortunately. But much like adults, it seemed to be things that are pretty common. Most of it was asthma or obesity, so not necessarily, what we consider sick kids, but just kids with common comorbidities.
Right, and I think this is where MIS-C is distinct from presenting with acute COVID-19 illness. And so there may be some overlap between those entities, but we did see that there wasn't a huge sort of disproportionate burden among children with, let's say, asthma. So so one of the things that we had really wanted to do, but we couldn't, was that, as I was mentioning, we were looking at race and ethnicity among New York City population, among our MIS-C cases, and then in COVID-19 hospitalizations. The one element that we couldn't do was to look at that same thing, that same distribution among all of our total COVID cases, because, and that's all over, that overall number would include people who are hospitalized and not hospitalized, people who are symptomatic and asymptomatic. And for those data, we just did not, for those cases, we just didn't have enough race and ethnicity information to be able to do that type of analysis. And so to really try to, I think the next stage of this type of work would be to really look at the distribution of race and ethnicity among overall cases, among those with severe disease and hospitalized, and among those with MIS-C. To really, I think, the interpretation of these data are limited if you don't have that other component.
Right. And I think, again, that kind of resonates with a lot of the other challenges we had with some of the epidemiology in the pandemic here, is that with the combination of both the long tail of people with relatively minor disease who do pretty well, who don't ever seek healthcare necessarily, as well as kind of the still being so far behind the ball in testing that we just don't know really how big the iceberg is under the water. So it's so hard to make comparisons.
It's true. I think that there are both issues with how variable testing has been throughout the pandemic. So certainly in New York City, we had to be so restrictive based on availability of testing and CDC guidance early on. And then obviously there's been an expansion of testing. So part of it is we don't have all the cases diagnosed, certainly. So there's just, you can't ascertain all the cases. But the other element of that's really critical and that was precluding our additional analysis was that you just don't have the race ethnicity data for those cases, or for a lot of those cases. It's not something that people would commonly report when they report their laboratory data. And so there's more guidance and different actions both at our New York State level and at the federal level to improve that reporting. But for us still, we are still missing about more than 50% of race and ethnicity information for our overall COVID cases. When we investigate cases on an individual, a patient level, we're able to obtain that information generally. But broader scale, it's we tried multiple things to try to get at those data, and there's a team of data analysts that are trying to extract race and ethnicity data where it's available, but that does end up being a limiting factor for this type of analysis.
Yeah, that sounds really difficult, unfortunately. And then lastly, we've had a lot in the last number of weeks on different treatments, things like antibodies, as well as the more basic things like steroids for people who are very sick with COVID. What is it? Is there any directed therapies for MIS-C, or is it really just supportive critical care?
So the important thing with MIS-C is that it does seem to encompass sort of a range of severity, and so I don't think that there is sort of a package of therapeutics for all cases of MIS-C, and that sort of range of severity and the heterogeneity of clinical presentation is still being described right now. And so I think so much is sort of, speculation about the pathophysiology, but there is guidance from the American College of Rheumatology for the evaluation and management for MIS-C. And then in terms of sort of longer term goals, there is an international effort to try to look at best available treatments for MIS-C, and hopefully there'll be data coming from that. But for now, the number of cases is pretty low, relatively speaking, and so even the concept of trials just wouldn't really be appropriate or applicable in this context.
Right. I mean, that's one of the few silver linings here is that despite how bad the pandemic is, it really doesn't seem to affect kids that much. Obviously,
right.
223 kids with MIS-C is far too many, but it's not the huge numbers that I would have expected if you were to say, hey, there's a respiratory virus that's similar to colds that gets people really sick. So
right. I do think it's important for other parts of the country. So, granted, we had this huge burden of COVID in the springtime, but as other parts of the country, unfortunately, see more COVID, I think it is something that people should ideally be thinking about as they see kids in the ED and their outpatient settings.
Absolutely. Well, thank you so much. This is really important work, and I appreciate your time coming to share with us as well.
Thanks so much. I appreciate it.
Of course, join us again next week. We'll be back to our regular time, Tuesday, December 15th at 3 p.m. Central Time. Follow our usual social channels. And of course, you can get this paper and more at JAMAnetworkopen.com, where everything is free and open access. And we've got new papers coming out every weekday at 10 a.m. Central Time. So, of course, stay safe and take care. Thanks again.
Thank you.